Hello, welcome back to this channel. Today the topic of our video is Alzheimer's disease. So what is Alzheimer's disease? Alzheimer's disease is basically a progressive impairment of memory and cognitive functions. So there is a question that Alzheimer's disease and dementia are same or not. Dementia, that is a memory decline that occurs normally with the age, but Alzheimer's disease is basically a pre-senile dementia with the same pathology that underlies with the dementia. Now, Alzheimer's disease also refers to dementia that does not have an antecedent cause such as stroke, brain trauma, or alcohol that can cause impaired cognitive functions. So what is prevalence of this disease? Its prevalence basically rises with age from about 5% in 65 years old persons to 90% in at the age of 95 years. Alzheimer's disease is basically from the result of loss of neurons that occurs throughout the life. Pathogenesis of this disease include basically amyloid plaques and neurofibrillary tangles that causes loss of neurons, particularly cholinergic neurons of basal forebrain. What are these amyloid plaques and neurofibrillary tangles? We would discuss later. Amyloid plaques are basically aggregates of alpha-beta fragments of amyloid precursor protein. Amyloid precursor protein is the normal neuronal membrane protein. In Alzheimer's disease, what happens is there is excessive formation of this alpha beta fragments of this protein, and when there is excessive formation, the aggregates of this alpha beta fragments uh, forms a plaque that is called amyloid plaque. Neurofibrillary tangles are basically intracellular aggregates of highly phosphorylated form of a normal neuronal protein, that is tau protein. Tau protein is a normal neuronal protein, and its hyperphosphorylated form gets aggregated inside the cell and forms this neurofibrillary tangles. Both this hyperphosphorylated form of tau protein or neurofibrillary tangles and amyloid plaques, they both act and causes neurodegeneration, that is an important mechanism for the pathogenesis of Alzheimer's disease. Familial Alzheimer's disease is a term that results from mutation in the amyloid precursor gene or presenile genes that is involved in gamma-secretase function. Gamma-secretase is important in the formation of alpha-beta fragment of amyloid protein. So both these mutations cause increased alpha beta formation, and then increased alpha beta formation causes the formation of amyloid plaques, as we have discussed earlier. Next is a mutation in lipoprotein ApoE4 also increases the risk of Alzheimer's disease by interfering with alpha beta clearance. When there is no clearance or excretion of this alpha beta fragment, then there is increased levels of this alpha beta fragment, and then they get aggregated to form amyloid plaques. This picture shows a healthy neuron that contains this normal tau protein, that is a normal neuronal protein, and then this is a diseased or neuron with Alzheimer's disease, in which there is hyperphosphorylated form of this tau protein that form neurofibrillary tangles and amyloid plaques that is due to the A beta aggregates of amyloid precursor protein. So normally this amyloid precursor protein is cleaved by gamma secretase and alpha secretase and then forms a soluble peptide, but in the diseased one, the amyloid precursor protein is cleaved by gamma secretase and beta amyloid converting enzyme and then form this A beta fragments. Then first A beta monomers are formed, and then oligomers are formed that aggregates to form amyloid plaques. Amyloid plaques then causes this injury or oxidative stress that and other factors including cell death and activation of kinases causes this normal tau protein that is present on this microtubule to get hyperphosphorylated. Kinases causes the phosphorylation of this tau protein, and this is the hyperphosphorylated form of tau protein. And then this hyperphosphorylated tau protein forms neurofibrillary tangles that is shown here in this neuron. These are neurofibrillary tangles, and these are amyloid plaques. So this picture also shows a diseased neuron where these A beta fragments forming amyloid precursor protein are present, and this tau protein is present. These factors show these factors are important in improved resolution or the reverse of neurodegeneration, that are pro-inflammatory cytokines, microglial activation, interleukin 10, phagocytosis of A beta. These factors would improve cognition and would not cause the disease or neurodegeneration. So what are therapeutic approaches in case of Alzheimer's disease? Pharmacological intervention would only provide a palliative care, but they would not alter the underlying neurodegenerative process. So there are two treatment options in case of Alzheimer's disease that include acetylcholinesterase inhibitor, that are donepezil, galantamine and rivastigmine, and N-methyl D-aspartate receptor antagonists that include memantine. In case of cholinesterase inhibitors, tacrine was the first drug approved for treating Alzheimer's disease. The trials of this drug showed modest improvement in memory and cognition tests in about 40% of Alzheimer's disease patients. But this drug has a lot of drawbacks. For example, it had to be given in 4 times a day, and it has a lot of cholinergic side effects including nausea, cramps, hepatotoxicity. So later improved drugs that have limited efficiency, but they are more effective in improving quality of life, including donepezil and rivastigmine, galantamine, were added in the treatment options. So what is the mechanism of action of these drugs? Acetylcholine is basically a neurotransmitter in the at the synaptic junctions or in axons. So this enzyme acetylcholinesterase causes the degradation of acetylcholine. So the inhibitors of these enzymes would inhibit the action of acetylcholinesterase, increasing the level of acetylcholine at the synaptic terminals. The increased level of acetylcholine would improve or increase the cholinergic transmission in still functioning neurons. It would not alter or improve the diseased neuron. It would increase the transmission in healthy neurons. Other cholinesterase inhibitors include galantamine, that also augment the action of acetylcholine by inhibiting this enzyme at nicotinic receptors, and it causes the reduction of rate of loss of cognitive function in the diseased patients. Rivastigmine is basically the only agent that is approved for the management of dementia associated with Parkinson's disease, and it is also the only drug that is available as transdermal formulation. So these drugs also have a lot of adverse effects due to their cholinergic functions that include nausea, diarrhea, vomiting, anorexia, tremors, bradycardia, and muscle cramps. So this table shows the various treatment options that are important in case of Alzheimer's disease. First drug or first cholinesterase inhibitor is tacrine, that affect both acetylcholinesterase enzyme and butyrylcholinesterase enzyme, that is another important cholinergic enzyme found in plasma. So this drug is not CNS selective because it is affecting both these enzymes. It has to be given 2 to 3 times daily, and it has various cholinergic side effects as we have discussed earlier, include pain, nausea, vomiting, diarrhea, and hepatotoxicity. So this need to be monitored in case of treatment. Next drug is donepezil. It is CNS selective and also affect only acetylcholinesterase enzyme that is present in CNS. It has to be given once daily, and it has less severe cholinergic side effects than tacrine. Rivastigmine, it is also CNS selective, but it has to be given twice daily, and its cholinergic side effects subside with continuing treatment. Galantamine, it affects both, like tacrine, it also affects both acetylcholinesterase and butyrylcholinesterase enzymes. It has to be given twice daily, and it also has minimal cholinergic side effects. Second important group of drug that is important in the treatment of Alzheimer's disease is N-methyl-D-aspartate receptor antagonist. N-methyl-D-aspartate receptor is basically the receptor for glutamate, that is an excitatory neurotransmitter present in brain. The only drug that is in this group include memantine. Initially, these drugs were introduced as antiviral drug, but later they were reassured as inhibitor of excitation or inhibitor of neurotransmission by glutamate enzyme. These drugs improve cognitive function, but they are not neuroprotective. So glutamate is a normal enzyme that is present in brain. This enzyme binds to this NMDA receptors that causes the opening of ion channels, and this opening of ion channels causes influx of calcium into the cells. Then this intracellular calcium activate various cellular processes that causes the damage of neurons and lead to apoptosis. Normal function of this glutamate in the cell is the formation of memories, but when there is overexcitation of this glutamate by binding on NMDA receptors, it causes excitotoxic effects, and then the neurodegeneration and programmed cell death or apoptotic processes. Mementamine is the only NMDA receptor antagonist that is important for Alzheimer's disease. It binds to this receptor and then blocks the action of glutamate and then limits the influx of calcium, and then the apoptosis and various pathological processes involved in Alzheimer's disease. It basically works selectively. It inhibits excessive pathological NMDA receptors and preserves physiological activation. It has a long plasma life, and its adverse effects include headache, dizziness, drowsiness, constipation, shortness of breath, and hypertension. Thank you for watching this video. Stay tuned to this channel for watching more informative lectures like this.